Thanks for joining us here for another Fullscript webinar. We're super excited today to be joined by Dr. Nalini Chilkov L.Ac, OMD, founder of integrativecanceranswers.com. She's a leading edge authority on integrative cancer care, immune enhancement, optimal nutrition, and wellness medicine. She is the author of the best-selling book, 32 Ways to Outsmart Cancer, How to Create a Body in Which Cancer Cannot Thrive. Dr. Nalini's Outsmart Cancer programs are recognized as some of the most comprehensive, science-based, safe, natural programs for supporting cancer patients, cancer survivors, and those who do not want to get cancer to get well, stay well, and live well beyond cancer. For over 30 years, Dr. Nalini has helped thousands of people, many of which have serious and chronic illnesses, achieve and maintain extraordinary health and longevity. She is sought out by award-winning Hollywood celebrities and insiders. She has appeared as a health expert on NBC TV and has been recognized by WebMD and Dr. Mehmet Oz's sharecare.com as one of the top 10 online influencers in breast cancer. She writes a very popular blog on health and wellness and cancer prevention and recovery for the prestigious Huffington Post. Celebrity nutrition and fitness expert and New York Times best-selling author J.J. Virgin says, "I send all my friends to her." Nationally famous physicians such as Dr. Frank Lipman, MD, and six-time New York Times best-selling author Dr. Mark Hyman, MD, call her my go-to resource. Dr. Nalini, I know you're very busy. Thank you so much for joining us today, and you can take it away.
All right. Thank you, everyone, for attending. This is a really important topic in cancer care. Inflammation is core to the ecology of cancer. And so I want to give you a lens into how inflammation really influences cancer and what we can do about it, because it's so important. A lot of people don't realize that not only do cancer cells themselves produce a lot of inflammation, but also a body that has inflammation in its terrain, in its microenvironment, also is a setting where cells can be damaged and cancer can arise. So we have inflammation coming both from the physiology as well as the tumor cells themselves. So let's take a look at exactly how we're going to understand this more deeply. For those of you who are clinicians and really want to be feeling confident working with patients who have a history of cancer, who may have a risk of cancer, who may be going through treatments, or who might be living with cancer as a chronic illness, it's really important to know how to take a good history, which would be different from a patient whose life has not been touched or threatened by cancer. So after this webinar, I encourage you to click on this link and download the Survivor Thriver Care Planner, which is a document that will help you understand how to take a good history of this patient population and therefore understand what to pay attention to when you're putting a care plan together for them. Now, first we have to understand the cancer terrain or the landscape of cancer. So we have to understand that there's really an absence of a health model in oncology. And so in functional medicine, in naturopathic medicine, in integrative care, we really want to hold up the foundation of health for the patient and be part of a collaborative team that supports the patient towards health. In an oncology setting, the word health isn't in the lexicon at all, but that's what's most important to the patient. And so we really want to make sure that there's a health plan right from the beginning for every patient, not just a disease plan. And that's sort of how I talk to the oncologist about it as well, so that we have a seat at a table, we have a voice in the team, and that the patient feels that there is a plan for their health all the way through, right from the beginning. And the reason this is really important to understand is because today the statistics are pretty daunting. 1 in 2 people in the United States, Canada, Europe will be diagnosed with cancer of some type in their lifetime. Now, those are daunting odds. Think if you're sitting at a dinner table and half the people at that table fall into this category. But what's good news is that people who have been diagnosed with cancer actually are surviving and living longer. So 2 out of 3 people who are diagnosed with cancer will actually survive. And then those people actually need our help to maintain their health and well-being and to reduce their risk of recurrence. So it's really important that we be able to do that for these patients who will be turned back to their primary care providers. And so if you look at these statistics, it's really incredible. By the year 2020, there's going to be 20,000 cancer survivors in the United States alone. So it's important that we be prepared to care for them, and looking at their inflammation status is part of that. For those of us who did not specialize in oncology but have primary care frontline practices, that means we never had more than a semester of training in oncology. And so primary care providers are solely unprepared to take care of this patient population. So that's sort of part of my mission, is to make sure that clinicians really understand how to meet the needs of these patients. And then you can think of yourself as the health expert in your community for patients concerned about cancer. And then if you develop your skill set and your knowledge base, then you can also be a referral for clinicians who really want to serve their patients well, but don't have the knowledge that you have gained. So we always look at this tumor microenvironment because it's like the soil in a garden. It is the environment which is a signaling environment that either is sending oncogenic pro-cancer signals, or it is sending inhibitory anti-cancer control signals. And this has to do with gene expression. And so the way I explain it to a patient is, if you change the soil in a garden, you change what grows there. And so conversely, if we understand the tumor microenvironment and we can alter that with diet, lifestyle, nutraceuticals, and botanicals, and work together with the oncology team that the patient has, then we can really impact the trajectory of the disease. And so inflammation is part of this. And we want to really inhibit tumorigenesis and progression and metastasis and invasion, and really promote inhibition of this progression. And so when we look at the cancer terrain, we want to look at a lot of things that we already look at in functional, integrative, and naturopathic medicine. And those things include looking at glycemic control, signaling for metastasis and angiogenesis, the progression of cancer, looking at how to modulate immune function, looking at detoxification function, how to turn back on signals for natural cell death, which are turned off in tumor cells. This is the function of apoptosis that occurs in the mitochondria. Cells should recognize themselves as aberrant and commit suicide, go through apoptosis naturally, but cancer cells learn to be immortal by turning off this apoptotic switch, and so inflammation influences this. We want to be aware of any occult infections that might be contributing. We want to look at hormone status, and the tumor microenvironment also is one of hypercoagulation, and inflammation contributes to this. 40% of all cancer patients will have a thrombotic event and may even die of the thrombotic event and not of the cancer itself. So by controlling inflammation, we are able to influence this larger tumor microenvironment. And of course, we all know that inflammation is really at the foundation of most chronic illnesses, and cancer really can be thought of as a chronic illness, a mitochondrial illness. Now, the way that I think about it, I think about cancer, the experience of the patient in phases. So someone may come into your office when they were just diagnosed. That's a particularly stressful time. My goal during that time is to reduce the patient's anxiety and to give them a sense of agency and control over what's going to happen to them, help them to be a more educated patient. A patient who comes into you in treatment is often complaining of side effects and toxicity from the treatment. Helping them to navigate that is very important. When a patient has completed treatment, we want to help them restore their normal healthy function. Managing inflammation is always part of that. And then hopefully we have patients who are going to have a life well beyond cancer, and we teach them how to create a body where cancer cannot thrive by teaching them how to manage the tumor microenvironment in the cancer terrain. And then there's a really large population of patients which really need us, and those are patients who are living with cancer as a chronic illness long term. So that might be the more advanced cancer patient who, for example, a breast cancer patient who is not completely cancer-free, and so she may be on hormone therapy or long-term therapies to keep the cancer from progressing. That's an example. There are patients who are treated by their oncologists and don't achieve what is called no evidence of disease or cancer-free status, so they still have some tumor burden, and those patients do very well under our care. And so there are these different phases that cancer patients go through, and their needs are unique at each phase of that journey. The goal is to exert some control over the tumor itself, and at the same time nourish the patient so that they're robust and can mount an immune response and maintain their good digestive function and detoxification function. So control of inflammation influences all of this. And I've created this system called the Outsmart Cancer System that I teach to clinicians, and this understanding of inflammation is a very important part of that. And what we can expect to accomplish is really we can transform the trajectory of the disease. We can change the outcomes and change the prognosis of these patients. We can also do synergistic things that contribute to better oncology treatment results. Some of the things we do really enhance the oncology treatments that the patient's oncology team is using. We can definitely have a big impact on managing short-term and long-term effects of the treatments. And so a lot of the cancer treatments themselves are pro-inflammatory. And so understanding how to manage inflammation goes a long way to really promoting the well-being of patients. Some of the fatigue that cancer patients experience is rooted in high levels of inflammation. And then, of course, our job is to really provide a health model for the patient, both during their treatment, their recovery, and long-term. So that's sort of the high altitude view. And in this way, we can partner with the oncology team, the disease experts, and then be the health expert on the patient's team, or one of the health experts on the patient's team, and then do what I do. Is I really expect my patients to be outliers. I really expect them not to be under the bell curve of the usual statistical prognosis. I expect my patients to do a lot better than patients who don't engage in this kind of care. And I always say that to patients all along the way, and especially at the first visit. I tell them, the fact that you walked in the door here and are asking for this kind of support in a health model means you're going to be an outlier and do better than the typical patient. So let's now take a deeper dive into what I call onco-inflammation, the inflammation that's related to cancer in the oncology setting. And this is unique and has particular signaling influences. Now, having a tumor microenvironment, a cancer terrain that has elevated inflammatory cytokines will impact the amount of fatigue that cancer patients experience. increased inflammation also influences the brain. An inflamed brain is more vulnerable to depression. The inflammatory cytokines are growth signals, so we see more tumor growth, more proliferation, more progression, more metastasis, which is the ability of a primary tumor to establish secondary sites at other places in the body. This then becomes advanced disease. Angiogenesis is promoted in the milieu of inflammation. Angiogenesis is the capacity of a tumor cell to form its own blood supply. And once that primary tumor has a blood supply, that means that cells from the tumor can travel throughout the lymph and bloodstream and then become metastatic. And so the places where metastasis and secondary tumors are found are primarily the places where there's a lot of blood supply. So we see metastasis in the lungs and the liver and the brain and the bone marrow. And so these are the places where patients are most vulnerable to having secondary tumors take over these vital organs and functions. It is never the primary tumor that causes a patient to die. It is the metastatic disease that takes over vital organs that ultimately will cause death in cancer patients. So by controlling inflammation, we control these processes of progression as well. And then cancer cells are able to dismantle the immune system, and this is why cancer is so very challenging. So by controlling inflammation, we also have the ability to reactivate the suppressed immune system for the patient. Now, it's very important to understand this framework that's called the hallmarks of cancer. And this describes the unique characteristics of tumor cells. And these characteristics are the strategies that tumor cells use to survive. And they will actually co-opt our normal physiologic processes in order to survive and be invisible to the immune system, disable the immune system, to become immortalized, to not normally go through apoptosis. And so cancer cells are really smart. And so as you get more experienced in working with cancer patients, you start to think about all these hallmarks of cancer in your treatment plan. So the one that we're going to go over today is tumor promoting inflammation. And so realize that in conventional oncology, a lot of these factors are not taken into consideration. Maybe the treatment plan of an oncologist will focus on 1 or 2 or 3 of these hallmarks of cancer, but we can fill out the treatment plan and make it really comprehensive and coherent and address many more factors than the oncologist is addressing. And that's one reason our patients will do better. Now, it's very interesting to look at this graph. You can see that there's a direct correlation between inflammation and cancer survival. So the more inflammation that is present, the worse the survival. And that's because of all the factors that I just went through that in this environment of inflammation, we see that there is so much more proliferation and progression and disabling of the immune function. And under the condition of elevated inflammation, the patient's quality of life also is diminished because of depression and fatigue are generally present in states of high inflammation as well. And certainly pain can be increased in states of high inflammation. So we have a really great toolbox for working with inflammation for the patient. So one of the things that you want to be aware of is there are certain physiologic states that are pro-inflammatory. And some of these are infections. And so we want to be aware of the patient's history and understand if there are underlying occult infections that might be contributing to really elevated levels of inflammation on top of the cancer. So we want to be aware of, does the patient have a history of human papillomavirus. This contributes to cervical cancer and head and neck and oral cancers. We want to be aware of the microbiome and the history of bowel health, and really support the microbiome so that intestinal dysbiosis is addressed. Realize also that a lot of the treatments that cancer patients receive will disrupt their microbiome. And so we want to pay attention to that and make sure that we maintain that good, healthy boundary in the intestinal lining, and make sure that we have a proliferation of the healthy microbes and diminish the populations of the pathogenic microbes. We also want to know, does the patient have a history of autoimmune colitis or inflammatory bowel syndrome, because this will be worsened under the conditions of chemotherapy, surgery, and if you have radiation to your pelvis. So we want to be aware of that. We want to know if the patient has a history of hepatitis, because most chemotherapy agents and many other drugs used during the treatment of cancer patients are hepatotoxic. We want to know if there is a history of gallbladder or pancreatic disease or endometriosis. These are all inflammatory syndromes that may make the patient worse while they're undergoing treatment. We want to know if the patient has a history of parasites, and some of these infections can create an environment where very aggressive cancers can occur. So you can get hepatic cancers if you have infection both with virus or parasites in the liver. Cholangiocarcinoma is linked to the presence of liver flukes, and cholangiocarcinoma is one of the most difficult to treat cancers, and not so much in the United States in cancer, but schistosoma is a parasite more common in areas where there's poorer public health, and bladder cancer has been linked to that. So you want to also know if a patient has traveled internationally and may have had a history or an exposure to organisms like this. The presence of diabetes, the presence of obesity dramatically increases whole body inflammation and cancer risk. Patients who have a high percentage of body fat and a BMI of over 35 have a 40% increased risk of cancer due to inflammation and due to increased estrogenic signaling. Diabetes and patients with metabolic syndrome and insulin resistance have more inflammation and more growth signaling, because cancer cells have more receptors for insulin and GLUT4 and insulin-like growth factor on their cell surface. So managing healthy glycemic control and body composition is very important to controlling inflammation and cancer growth signaling. The Epstein-Barr virus is linked to lymphomas. Burkitt's lymphoma is an esophageal lymphoma linked to H. pylori in the stomach. So patients with a history of gastritis and esophagitis will have increased risk of those cancers. So taking a really, really good history and knowing what the patient has been exposed to will give you a sense of their pre-cancer inflammatory landscape. So you want to be sure you understand that, because the oncologist doesn't really think about those things. The oncologist gets really focused on the tumor. So we want to still have the big picture and the high altitude view of what's contributing to the patient's vulnerability and high levels of inflammation besides the tumor. So this slide shows you many of the things to think about. So you want to know, does the patient have an autoimmune history? You want to understand the tumor-associated contribution to inflammation, and then you want to understand the therapies that the patient is either receiving or has received that might be pro-inflammatory. So that's part of the cancer journey. But before that, did the patient have elevated levels of stress? Whether that was chemical and toxic exposures, did they have physical stresses, maybe they don't sleep enough. Do they have psychological stressors that impair their immunity and allow inflammation to increase and be poorly controlled? You want to understand toxic exposures as contributors to inflammation, and you want to understand what viruses the patient has been exposed to. As we just discussed on the first slide, there are a lot of infectious organisms, many of them viral and some parasitic, that contribute to cancer-related inflammation and then damage to the mitochondria and the DNA, which leads to the development of cancer. Also, you want to look at patients' eating habits, which is core to what we do. Does a patient eat a lot of grilled, fried food? Do they have a high red meat diet? All of these things are pro-carcinogenic. We mentioned H. pylori, we mentioned the microbiome in terms of bacterial triggers of inflammation, we mentioned obesity. So again, we want to really look at all the contributing factors and separate acute inflammatory issues from the chronic inflammatory issues. And it is these chronic inflammatory issues that really contribute to most chronic illnesses, but in particular in cancer, in a state of inflammation, the cell will transform, and then a transformed cell that becomes a cancer cell has a better chance of survival, proliferation, invasion, and progression, and becoming resistant to treatment than a cell that is in a low inflammation environment. And that's why it's so important. And then in the middle, you'll see all of the cytokines and enzymes that increase in the tumor microenvironment. And many of these we can measure in the bloodstream. And many of these are signaling molecules for the progression and growth of cancer. So this gives you the gravity and the weight and importance of the management of inflammation. And in our framework, we're not looking at the endpoint. We want to understand etiology and triggers and antecedents that contribute to this vulnerable state. Now, we know that NF-kappa-B is a nuclear factor that is an upstream factor that leads to many downstream inflammatory processes and molecules. So in the presence of activated NF-kappa-B, which is a master regulator of inflammation, we start to have these changes over time. Now look at the timeline at the bottom of this slide. This is a 20-year timeline, and the truth is that once a tumor has been identified, that cell, that original cell that first became the first transformed aberrant cancer cell, maybe that happened 10 or 20 years ago. And then other changes happened in the tumor microenvironment that allowed that cell to transform, survive, and proliferate. And so in the beginning, we have the insults that we described on the prior slide that may damage the mitochondrial DNA and the nuclear DNA and cause a cell to become a transformed cancer cell. And then those cells need to be in an environment where they can replicate. Once that happens, they have to figure out how to survive. And the hallmarks of cancer slide tells you all those strategies that allow cancer cells to survive. And these boxes below are signaling molecules that are found in the nucleus or the cytoplasm or the mitochondria that help cancer cells to survive. And so in an environment of inflammation, we tip towards these physiologies. Once the cell has figured out how to survive, then it further divides in a permissive environment. And then if it can produce its own blood supply, it will then be able to escape and invade the bloodstream and the lymphatic system and travel, and then metastasize to the vascular areas of the body where we'll see progression. So that's sort of the process, but what I want to impress upon you is how long this takes. So a tumor the size of a head of a pin is about 3 millimeters, and that size of a tumor is often what will be picked up on a scan. You can't usually see things smaller than that. And so that's why we want to be concerned with the tumor microenvironment and the cancer terrain. So we're dealing with the microscopic, not waiting for a macroscopic evidence. And so a tumor that's 3 millimeters has 1 billion cells in it. And so it took a while for that one aberrant cell to divide enough times so that there would be 1 billion cells in a 3 millimeter tumor. But the likelihood that at least one of those cells figured out how to escape the tumor mass and travel in the bloodstream is there. And that means that all cancers are a systemic whole body disease. There's no such thing as a cancer that's just localized. And the whole body physiology is going to contribute to whether or not cancer cells can proliferate and survive. So NF-kappa-B is triggered by all kinds of environmental stimuli. And so we talked about those on a previous slide, but again, you can see here that NF-kappa-B not only is triggered by insults in the environment, but then it will cause the production of TNF-alpha, interleukin-1, the rank ligand. These are all pro-inflammatory cytokines. It will increase interleukin-6 and STAT3, and these are all big growth signals for tumor cells. It increases the presence of COX-2 and LOX5 and the prostaglandins and chemokines. So this becomes a chemical soup filled with inflammatory cytokines, and we want to be able to exert some control over that. And we'll see not only cancer, but other types of inflammatory syndromes, autoimmune diseases, and other syndromes like diabetes and obesity, allergic syndromes, Crohn's. All of these chronic diseases and cancer share this environment of high inflammation. And so again, you need to be aware of the triggers. You need to be aware of where we can intervene and exert control. So this is the influence of NF-kappa-B on growth signaling and on those hallmarks of cancer. And so we're going to look at how we actually decrease NF-kappa-B, TNF-alpha, and the common inflammatory cytokines with our toolbox. So you can get a sense of what's going on in the cancer terrain from some very simple blood tests that you should have in front of you. And when we have systemic immune inflammation, that shows up in biomarkers, and that tells you there's an increased risk of cancer, an increased risk of mortality, and decrease in survival prognosis. And so it's important to shift these, and you can easily measure these. So C-reactive protein will always be increased in this setting. My goal is to have C-reactive protein be below 1. You will see advanced cancer patients will have C-reactive proteins over 20 quite often. In patients with increased inflammation in the cancer terrain, you can calculate the neutrophil to lymphocyte ratio from a CBC. You can also calculate the platelet to lymphocyte ratio when you have a CBC in front of you. And when those are increased, you have a worse prognosis. So I like to see the neutrophil to lymphocyte ratio below 2, ideally. Anyone who has a neutrophil to lymphocyte ratio below 2 has a pretty good prognosis. If it's above 4, their prognosis is poor, and I will expect that their cancer will progress. So you can look at these things and see if your interventions are making a dent, and that is important. Platelets also are part of the inflammatory and the increased coagulation environment, and so you want to take a look at those. Now, certainly some therapies like chemotherapy will decrease platelets, but in the environment of cancer progression, you'll often see this ratio increase of platelets to lymphocytes. And at the time of diagnosis, you can sort of look at this landscape if you're seeing the patient there, or let's say you have a patient and you see this and they're not diagnosed with cancer, these are red flags to raise that question. And quite often, the primary care frontline clinician might be the first one to see a landscape of cancer and then bring that to the attention of the patient's team, so that you can start looking to see if there's early cancer. And that's a role that we play. That's very important. We tend to look more carefully at our patients. When you have a patient who either at the time of diagnosis or during their cancer journey starts to have decreased albumin, so that the albumin to globulin ratio goes down, that's a sign that the patient is really declining and the cancer is progressing, or that they have a poor prognosis. So the albumin to globulin ratio would be seen in the metabolic panel that you should also have in front of you. So just with a CBC and a metabolic panel in front of you, which are routine blood tests that are done in most practices, you can see this cancer terrain developing and either progressing or improving. As I mentioned before, when you have diabetes and hyperinsulinism and you have a hemoglobin A1C over 5.2, you're going to have disease progression. You'll see, if you measure them, the interleukins 6, 8, and 1 are typically increased in the tumor microenvironment. When you have obesity and a BMI over 30 to 35, you have more inflammation and disease progression and more risk. Ceruloplasmin is an inflammatory marker that is increased in the tumor microenvironment. CA125 is not only a ovarian cancer tumor marker, but it is also a reflection of inflammation, as is ferritin. So it's not only an iron storage molecule, but it's an acute phase reactant in inflammation. And certainly if you have a patient who also has autoimmune syndromes, they're going to be more at risk and have a poorer prognosis. And interestingly, vitamin D levels are also linked to the inflammatory state. And patients who have serum vitamin D3, 25OH vitamin D, below 55 have a poor risk of survival. So you can take a look at some of these more common factors that you'll see. And so just summarize some of them here so that you could have a little cheat sheet for yourselves looking at some of these factors. You can also calculate the ratio of CRP to albumin, and that also if you have elevated CRP and lower albumin, then you have a higher risk also. When you see the white blood cells increase, you know that you're in a state of higher inflammation, and that produces a state of higher coagulation and thrombotic risk as well. So you can take a look at these, and I have some references for you so that if you're interested, but you can see that a lot of these inflammatory factors are linked to multiple cancers, basically. And the pre-treatment status might be something that you see before the patient is even diagnosed. There's a systemic immune index that can also be calculated, which is the platelet count times the neutrophil to lymphocyte ratio. And if that's over 475, you have an aggressive environment with poor survival and high progression. So again, I put these before you so that you can see if maybe you have a patient in your practice who actually has a landscape of cancer that you might not have recognized before. And so I have references for you. Now let's look at some of the dietary factors. Certainly we all know that you can't talk about any health condition today without talking about dysbiosis and the microbiome. And there are definitely references that show that dysbiosis not only increases systemic inflammation, but we now know that it also influences the metabolism of chemotherapy agents as well as immunotherapy agents. So a healthy microbiome is actually going to not only improve immunity, but improve response to treatment. A healthy microbiome will downregulate pro-inflammatory cytokines and upregulate anti-inflammatory cytokines. So our work is cut out for us there. And in terms of food therapies, the most important thing is really to make sure that there are plenty of soluble prebiotic fibers in the patient's diet, and this comes from plants. And we always want to encourage patients to have fermented foods in their diets, and certainly in all cultures there's traditions of fermented foods. Find something the patient likes, and this would be as a condiment, not as a giant serving. So a teaspoon of sauerkraut or kimchi, or a small amount of cultured goat or sheep's milk cheese in a salad, a little bit of sauerkraut. These types of things don't have to be eaten in large amounts, but if you inoculate the gut with food with a wide variety of microbes, that's better than taking a supplement, actually. Now, it's not too hard to get soluble fibers in the diet. The biggest families are the onion, garlic, and the cabbage family, cruciferous vegetables. It's really not hard to get patients to increase their prebiotic fibers, but it is really the presence of these soluble fibers that allows healthy bacteria to colonize. A lot of the probiotic supplements that we give to patients just go right through us. If there's not an environment in which they can colonize, then you don't get a lot of value. So it's not so much about taking billions of organisms as it is in having an environment with soluble fibers that allow the production of short-chain fatty acids in the gut. And that's really important. If for some reason the patient isn't really going to eat the way you are asking them to, then of course we have functional foods that are sources of prebiotic fibers. And by doing this, we decrease whole body inflammation, not just colonic inflammation. And so I find some of the fibers like acacia gum, for example, and inulin, which you'll see, and pectin, which you'll see in a lot of fiber products, those don't cause as much gas. If a patient has small intestine bowel overgrowth, they can get a lot of gas when you introduce fiber. I found acacia gum doesn't do that very much. Or you'll see some products that are made with resistant starches, and those tend to not be so gassy and create so much abdominal bloating, but at the same time they have the capacity to be fermented in the gut, in the lower intestine, and produce short-chain fatty acids and allow the healthy bacteria to really grow. Now, ketogenic diets are all the rage right now, and a lot of recommendations. And so it's noteworthy that ketogenic diets are actually anti-inflammatory. They also are anti-angiogenic, meaning that they inhibit the ability of a tumor cell to make a blood supply and become metastatic. And they also influence the tumor cell's ability to transform back into a more healthy cell that is able to go through apoptosis. So the ketogenic diet has a lot of factors because tumor cells preferentially use glucose. If we keep insulin and glucose low in the serum and preferentially ask cells to use ketones as fuel, a normal cell can do that. A cancer cell does not use ketones efficiently and therefore becomes stressed in a ketogenic diet. And so under the influence of a ketogenic diet, we increase the activity of the mitochondria to go through oxidative phosphorylation instead of glycolysis. Tumor cells prefer glycolysis. This is a metabolic change. And so ketogenic diets are a metabolic therapy, essentially, that then influence these hallmarks of cancer and turn the physiology back towards normal. So cancer is really a metabolic disease, and the primary organ in the cell, the mitochondria, which governs cellular metabolism, is where ketogenic diets primarily exert their effects. And so we can reduce proliferation and growth and angiogenesis and decrease inflammation. So ketogenic diets are valuable in that way. Ketogenic diets traditionally have a ratio of very high fat, up to 75% of calories from fat, as low as 15% of calories from protein, and very low, 5 to 10% of calories from carbohydrates. This is a tough diet to do, so a modified diet is easier for patients to maintain. The brain cancers get the most impact from ketogenic diets, and so there's a modification where you can loosen up some of those ratios, but a high-fat diet is going to be more anti-inflammatory, and promoting an anti-inflammatory diet means that we want to teach patients how to eat healthy fats and oils and increase omega-3s as much as possible and downplay the omega-6s. So if a person is on a plant-based diet, then you need to emphasize things that are higher in the omega-3s as well. So flax and walnuts tend to be the highest in omega-3s, but teaching patients how to add healthy nuts and seeds and nut butters to their diet and how to incorporate them is really important. Avocados and the monounsaturates like olive oil also are really important. But a lot of patients who are new to this, they really need to understand how to use these foods and make them a big part of their diet rather than just snacks. MCT oil, medium chain triglycerides from coconut, have a really, really big impact on ketosis and are a very readily available source of nutrients because they don't really need to be broken down, and they can be absorbed through the small intestine right into the liver. And so for patients who are fatigued and have poor digestion, I'll add MCT oil to their diet and to therapeutic shakes, and it not only tips them towards ketosis, but it gives them a ready source of energy. For patients who are not just plant-based, there are, of course, the omega-3s are higher in animal products such as wild-caught cold water fish like salmon and cod, mackerel, and sardines. High omega-3 free-range egg yolks are a great source of omega-3s, and of course grass-fed butter from cows that are raised grazing and hormone-free are really high in omega-3s as well. So let's look at, in the nutraceutical and botanical toolbox, what we can use. Now, I've made a couple of slides for you here that show which inflammatory cytokines are influenced by some of our materia medica. And I do this just to impress upon you that natural medicine is really full of multitaskers. So we get a wide range of influence. Unlike drugs, we give a handful of things and we impact multiple pathways. And so this is the power of using natural medicine and molecules from nature, which readily bind to receptors, also unlike synthetic molecules. So the green tea catechins, particularly EGCG, which is known to influence tumor growth, is also an anti-inflammatory catechin. Curcumin is always in the conversation in cancer, and the curcuminoids not only influence many signaling pathways in cancer growth, but also exert a lot of influence on inflammation. Of course, the omega-3 fatty acids are very, very powerful, particularly in inhibiting prostaglandins, COX-2 and LOX5, and then if you see a high CRP, you can think about, if you need to just pick two things, pick curcumin and omega-3 fatty acids. I put a dose range up at the top of the slide there, 2 to 4 grams a day of each of these things. So you don't have to do everything on this list, but you can see what's most appropriate for your patient. Probiotics we just talked about. Scutellaria bicalensis is a Chinese herb that is used in almost every herbal cancer formula in modern China. It contains polyphenols and alkaloids, which are not only anti-inflammatory, but exert a lot of tumor control. It's one of my absolute favorite botanicals to use with cancer patients. Ganoderma's reishi mushroom. A lot of people don't realize that the medicinal mushrooms have anti-inflammatory properties, and not just immune stimulating properties, but also anti-inflammatory properties. Resveratrol not only impacts mitochondrial function and telomeres and longevity and cardiovascular health, but it actually, resveratrol and other stilbenes like pterostilbene from blueberries actually have anti-inflammatory activity as well. Andrographis is a Chinese and Ayurvedic herb that most people who study this herb are familiar with it as a super antiviral, but it also is a super anti-inflammatory, and it has some other anti-tumor effects. So what I've put on this slide is materia medica that is not only anti-inflammatory, but also has other signaling that impacts tumor cells. And similarly, on this slide, we have some additional things that I use. Boswellia is one of my absolute favorite botanicals to use. And it's the alpha ketoboswellic acids that actually have the biggest impact. So when you select a product, you want to make sure there's a high percentage of those. That targets primarily the LOX5 pathway, the leukotrienes, which are very prevalent in the lungs and the large intestine. So in lung cancers and in intestinal colorectal cancers, I'll use this a lot, but I'll use it a lot if someone's having inflammatory symptoms in their GI tract from treatment as well. All the sulforaphanes, not only do they interfere with tumor cell proliferation at every stage of cancer cell development, but they also downregulate nuclear factors that lead to inflammation. So this is a very upstream intervention. And so I really, almost all of my treatment plans include sulforaphanes. Ginger is not to be forgotten. It's not the most exotic botanical, but it has so many positive impacts on the cancer terrain. But one of those is inflammation. It has anti-nausea effects. It actually has some anti-tumor effects. Of course, we want to be supporting digestive function in patients undergoing the therapies that damage the GI tract and digestion. So I often have ginger in my protocols as well. Andrographis, we already mentioned. Feverfew, Tennessee parthenium, is one of the most powerful anti-inflammatory, anti-tumor agents. I also use that quite a lot. And many people don't realize that ginseng actually has anti-inflammatory activity. And remember that cancer patients are tremendously fatigued, and thinking about adaptogenic herbs is important. So again, I just put these here to show you that the herbs that you may already be familiar with, and the phytochemicals you may already be familiar with, have a place in the cancer terrain, in the tumor microenvironment, in the treatment plan of cancer patients. Start to think about them more as multitaskers and being able to be used in different environments. And then I've just included here some reference papers for you that have studied the anti-inflammatory properties of some of the botanicals that I have included here, the Andrographis and the resveratrol. So this paper shows resveratrol decreasing CRP and TNF-alpha and interleukin-6. So start to think about these things that you already may be using in other ways in a very much more wide way. This is a great paper on curcumin if you want to understand more about the pharmacology of curcumin. Dr. Agarwal has published many papers on curcumin, and this one is focused on its anti-inflammatory properties. And this is an infographic from one of his papers that shows you all the anti-inflammatory pathways and tumor-related pathways that curcumin affects. We actually know that curcumin interacts with over 50 different pathways that influence tumor cells. Remember, curcumin needs to be taken in a lipid medium, so you want to use a product where you either have an emulsified product or instruct the patient to take their curcumin with a meal that contains healthy fats. A lot of people don't think of the omega-3s as belonging in a cancer terrain, cancer prevention kind of a protocol, but not only do the omega-3s decrease inflammation, which I think most people are familiar with, but also signal tumor cells in terms of inhibiting proliferation and adhesion. So again, they're also multitaskers, but you can see when you introduce omega-3s at therapeutic dose ranges that you'll actually see decreases in the C-reactive protein levels in the serum and in the C-reactive protein to albumin ratio. And so you can actually measure the impact of your interventions. Now, I haven't talked about tocotrienols, but these are a bit coming into more of the foreground in integrative and functional naturopathic medicine. Tocotrienols are in the vitamin E family, and they actually compete with the tocopherols. So using tocotrienols therapeutically, you want to take them separately from any tocopherol supplements the patient might be taking, so that might be their multivitamin. But tocotrienols have a really powerful anti-inflammatory effect. They also enter some of the pathways that are very proliferative in cancer cells like STAT3, and they're really great at reducing arachidonic acid, which of course is one of the most pro-inflammatory cytokines or prostaglandins in our system, and will downregulate glutamate in terms of neurotoxicity. And glutamate is upregulated in anxious patients as well. Neurotoxicity is an adverse effect of a lot of oncology treatments, so you can think of it that way. If a patient is receiving a pro-oxidative therapy from their oncologist, and that would be radiotherapy or some of the common chemotherapy agents, they just withhold the tocotrienols during the infusion or active radiation phase, and then you can reintroduce them afterwards. But Dr. Barry Tan is a principal researcher of tocotrienols, and he has several papers showing that tocotrienols are active in breast, prostate, colorectal, ovarian, and pancreatic cancer. And I usually give about 600 milligrams a day of this. Remember that your diabetics and obese patients are going to be higher in inflammation, and so you want to monitor inflammation in those patients with the blood tests, the biomarkers that we already discussed. Curcumin's been studied both in diabetes, obesity, and the cancer settings. So you might not be thinking about curcumin with your diabetic or obese patients, but it has a place there. This is also another paper by Dr. Agarwal in which he also showed that red chili, cinnamon, cloves, black pepper, and ginger exert influence in inflammation. And so these are ways to teach patients to make their kitchen their pharmacy. Not only is Ganoderma anti-inflammatory, but it does have anti-diabetic and anti-obesogenic effects. It actually influences TPAR gamma, but it also, because of the fibers in these mushrooms, also influences gut bacteria and the intestinal microbiome and improves the short-chain fatty acid production in the gut, which is our pathway to having a healthy microbiome. And so again, just to think about these materia medica tools that you already might be using, like reishi mushroom, in a broader way. Another paper on omega-3 fatty acids and risk of breast cancer, particularly in obese patients. If you have a patient who has a high percentage of body fat and a high BMI, they're much more at risk for cancer. So there's often a teaching moment after someone finishes their therapy to help them to really change their diet and their lifestyle. Some more references on omega-3 fatty acids. Berberine is the phytochemical found in many botanicals, including the Scutellaria bicolensis that I mentioned, but it's also it's what makes golden seal yellow. And so you can use any number of these herbs as a berberine source. Lots of references on berberine and inflammation. Berberine also has a very powerful influence on the microbiome. So there are a lot of products that I use. So I've just given you some examples here of products that I actually use in my practice, and you can come back to these slides and take a look at them. And these are products that contain the phytochemicals that are in these slides. And I also include a therapeutic shake in my protocols to address the increased needs for nutrients and for patients who just don't feel like eating. And again, I always put some C8 medium chain triglycerides into the protocol, and you can put these fiber powders into the shake as well. And that's a great way to get patients to be replete in their protein if they're not eating much. Introduce the healthy fibers and also the medium chain triglycerides. And so I'd be happy to take questions from anyone on the call now. And just remember that you can download this Survivor Thriver Care Planner so you can begin to get a sense of how to take a history of these patients and make sure you ask all the questions that will be part of a more comprehensive assessment for this patient population. So Cam, if you have any questions, why don't you let me know?
Yep, I have a couple questions here, Dr. Nalini. This one's from India Penny. There seems to be some instances of elevated liver enzymes with long-term use of curcumin. Any input on that?
I actually use curcumin in very high doses in some of my patients who have a lot of tumor burden. I use 4 to 6 grams a day, and in my practice, I have not seen that. So I would question the purity of the product that the patient is using because I have not seen that in my practice. So it's very important, the brands and the raw materials that manufacturers use. So I'm very, very particular about the brands of products because only a handful of companies really assay their raw materials for toxic contaminants. So my suspicion is that it's not the curcumin itself.
Great, and I have another one here from Valerie. She asks, how do you navigate the recommendation by the oncologist/hematologist of avoidance of vitamin K, including green leafy vegetables, while patients are on anticoagulants, given that emerging research indicates low-dose vitamin K2 actually helps stabilize fluctuations?
So this is where you as a clinician need to understand drug herb and drug nutrient interactions. It is only patients who are on Coumadin who must restrict vitamin K because it interacts with that one drug. Other anticoagulants, there is no vitamin K interaction. So if an oncologist has prescribed Coumadin to the patient to control their risk of thrombosis, then you do have to restrict vitamin K in that patient. But Coumadin is going out of use, and it's less and less and less common these days. So most patients are receiving the newer oral anticoagulants, and those have absolutely no interaction with vitamin K. So if an oncologist asks you to restrict K, then you have to ask them if they've prescribed Coumadin to the patient and let them know that that's the only drug with which our supplements interfere.
Great. A few more. Would you still encourage ketogenic diet if somebody has metastasis to liver?
So A patient who has metastatic disease to the liver is a patient with advanced cancer. And so at all times, we have to, and it is really our framework, to create highly individualized plans for our patients. A patient with elevated liver enzymes also usually feels pretty nauseous, pretty sick, and is having trouble eating. And so a really high fat diet might make them more nauseous. So in that case, we want to do a modified diet. So the answer to your question simply is I wouldn't put them on a strict ketogenic diet at all. I would put them on a low glycemic diet and a low carbohydrate diet. Make sure they get enough calories. Make sure that they don't lose muscle mass and go into sarcopenia. And also, you want to see a lot of patients with elevated liver enzymes. Sometimes it's from tumor mass in the liver, but sometimes it's from pressure on the liver. Sometimes it's a toxic reaction to a drug. So you also want to understand why the patient has elevated liver enzymes, because it might just be a toxic drug reaction, in which case the oncologist will withhold the drug, and then we can come in with things like N-acetylcysteine and milk thistle and help the liver to recover. And so you need to understand why a patient has a pathologic biomarker. For example, if the patient's a pancreatic cancer patient with liver metastasis and they just have a lot of tumor mass in their abdomen, then you just want to find a way to help them to eat enough calories. We always want to have a low glycemic diet because keeping blood sugar and insulin in the lowest quartile of normal inhibits tumor growth. So my strategy with these patients is to give them a therapeutic shake. And that shake will have a protein powder that the patient can digest easily. It will have MCT oil. It will have some fiber. I usually put some greens or reds powder in the shake, so it's a real meal substitute. And then I might add some Chinese mushroom powders to the shake as well, so that we're making it therapeutic in that way. We could even add milk thistle to the shake in this particular case. So, and then that patient might have 2 or 3 shakes a day if they don't feel like eating, so that they can maintain their caloric repletion and not lose weight and not lose muscle mass. But a patient like this is in trouble, and so we need to be monitoring them carefully also.
Awesome. And I have another one here from Kian. They're asking, what do you recommend for lymphoma induced by Epstein-Barr virus, specifically diet-wise or supplementation?
So first of all, that's a really complex question. And so I'm going to state first, if we know that a patient has a cancer induced by Epstein-Barr virus, the damage has already been done by the virus. So you can look at titers of viral antigens in the bloodstream to determine whether this is a historical exposure to the virus or a current exposure to the virus. So if there's active virus, then you would want to include antivirals in your treatment. But it may be that the exposure to Epstein-Barr was long ago, and it damaged healthy cells, which became lymphoma cells. So you have to determine that. However, if I am treating with a patient who has a cancer that is linked to viral exposures, I usually will include high doses of vitamin A in, not beta carotene, but vitamin A in the protocol, because vitamin A and also vitamin D cause differentiation of tumor cells. That means the cells are going to become less primitive and more complex cells are easier to treat than more primitive cells. And so I'll usually, with viral induced cancers, say cervical cancer and head and neck cancers, which are linked to HPV, I'll include vitamin A in the protocol to decrease viral activity. I'll monitor zinc status also to make sure we have good response to viruses. So vitamin D, vitamin A, and zinc, I'll always include those. I might include an herb like angiogenesis in a protocol for a lymphoma patient, because angiogenesis not only has anti-tumor, anti-inflammatory, but also antiviral properties. So you want to look for multitaskers. So vitamin A and zinc, for example, and D are all antiviral, but they also are anti-proliferative. So you start to build a plan out of our toolbox that addresses multiple characteristics of tumor cells and the tumor microenvironment. Now, this is a complex question because I can't give you a formulaic answer for it. So for those of you who are really interested in working with these patients, my Outsmart Cancer system walks you through how to build a treatment plan, how to assess the patient. And so for those of you who are interested, I invite you to take a look at the care planner. And if you opt into my list, you'll get 4 videos of me teaching some clinical pearls, and you can talk to us if you're interested. And then in the course, I do live mentoring. There's a live monthly Grand Rounds call where you can present your cases and I'll help you manage your patients. But there's no formulaic answer. Each cancer patient has to be looked at individually. You need to understand the tumor type. You need to understand the genetics of the patient. You need to understand what the oncologist is doing, and you need to understand the patient's tumor microenvironment. And on the basis of all those things and the stage of cancer, you build a treatment plan on the basis of all of that.
Awesome. And one last one here from Monica. When it comes to berberine, does it contribute to weight loss in an already underweight patient, or does it promote weight loss only in the diabetic overweight patient?
Berberine does not promote weight loss. It is not a weight loss herb. Berberine as a phytochemical is promotes insulin sensitivity. So when we have insulin resistance, we are in a fat storage physiology. When we repair that and there's increased insulin sensitivity, the patient will naturally stop storing fat and be able to burn it if they are not sedentary and they're not hypercaloric. So berberine is not a weight loss herb. And similarly, if a patient takes metformin and improves their insulin sensitivity, they naturally lose weight because you've changed their metabolism from a fat storage metabolism to a fat burning metabolism.
Awesome. And that's actually all the questions that we have for now. There are some people asking where they can download the slides, but I will be sending that out to everybody who registered for the webinar. In the next couple of days, you'll be able to download all the slides and catch the replay. As well, we'll be providing links to all those wonderful places you mentioned, like the Outsmart Cancer System, etc., for them to be able to access everything. So Dr. Nalini, thank you so much for joining us today.
Wonderful. Thank you for inviting me.